this one alone. She could tell right away that I was bad to the bone. Bad to the bone. Bad to the bone.
All right, Billy Cunningham, I invited in Dr. Brad Wenstrup of Wellington Sports Medicine to talk about what's happening in medical care in America today. And Dr. Brad, welcome again to the Bill Cunningham Show.
Thanks, Bill. Good to be with you.
You gave me this chart to my left, which I'm going to give to Jeff Henderson, which is put out by the federal government about the current healthcare system in this country.
Correct.
And this is pursuant to the beginnings of Obamacare, plus an ancillary issue is what the Obamacare is going to require of hospitals and insurance companies. And give me a macro overview of the status of health care in America today vis-a-vis the doctor and the patient.
Well, you know, thank you for letting me be part of the voice of the common man here. But the primary goal of health care is for the doctor to be able to see a patient and render care. I mean, that's the bottom line. And when you look at this chart,
that's it.
That's pretty much it. It's a pretty simple idea. When you look at this chart and you see how complex it gets and how many people get involved, there's so many people involved with your care that aren't caregivers and have never seen a patient and don't really have anything to do with the outcome of a patient's problem. And that's really where we're getting into trouble with a lot of bureaucracy and paperwork. And there's too many people that don't know the doctor, don't know the patient, that are getting involved. And
who is that person? Let's say Lindsay walks into you this afternoon, my producer, and she has a foot problem. Her ankle's killing her. And you do, what do you got to do CAT scans, x-rays, whatever it is? You just can't say, okay, Lindsay, let's get something done. And let's say she's with United Healthcare. What do you got to do? Or what if she's with Medicare or Medicaid? What do you got to do?
Well, you know, in most cases, you don't immediately run out and get an MRI or a CAT scan. You have processes you go through, conservative treatment, but that's based on your evaluation. If you suspect a fracture, you're going to take an x-ray. You're always going to do that. But if you suspect something more, you're going to dig a little deeper. And I can give you examples of sometimes the hassles that we get. I had a patient came in. She had a torn Achilles tendon. You could tell. You could stick your thumb in through it. She couldn't move her foot down. She knew it was torn. I knew it was torn. That has to be repaired. And so we order an MRI to evaluate how much of the tendon we have left, what are we going to need graft, et cetera. And I have to get on the phone with somebody at the insurance company who was then saying, well, did you get an ultrasound? I said, for what? I said, I need to plan the surgery. Patient knows it's torn. I know it's torn. So she goes, well, normally you get an ultrasound first. And so I've said, well, what is your specialty? And she said, oh, I'm an OBGYN. And I said, so why are you dealing with this? And eventually I got my way, and I can give you more stories like that. I had a patient who came in and said, I've had this pain in my foot for 10 years. And I've had X, Y, and Z done, all these different treatments, cortisone injections, padding, splinting, etc. And it still hurts. I said, well, at this point, you've had all those other things done, so let's get an MRI. So when I go to order it, I get on the phone with a doctor. They call it a peer-to-peer review, which rarely it is. And he said, well, that wouldn't be the first thing that I do. I said, well, you haven't seen the patient or evaluated them, and you haven't gotten their history, because there's a 10-year history of this problem. So why putz around? Let's go right to the MRI and take care of this patient. And when he said, this isn't what I do, I said, what's your specialty? He said, I'm an emergency room doc. And I said, well, then you'd probably refer to a specialist, which is where she is now. I said, so what would you do, doctor? And he said, well, I don't know, but it wouldn't be that. And I said, well, you must be very proud of the work you're doing these days with your degree. And I said, I hope this call is monitored for quality assurance because I want someone else to hear this. Well, the next day we did get approval. But this is what we have to go through. So
you have to give asses and elbows to these peer review specialists. Otherwise, you can't cut through the clutter and actually become a doctor and do care for the patient who needs it. You have to be the squeaky wheel.
And you feel like you're just a technician. And why am I even here if you're going to decide what they need and you haven't even seen them or talked to them? You know, it's really important in the doctor-patient relationship that perhaps you examine them, take their history, be a part of it, not just be able to call in and say, well, what do we do now?
What if they say no? I guess sometimes they say no.
Well, sometimes they'll say no, and they say, well, I'm not saying you can't go ahead and get the test done. We're just not going to cover it.
Then what? You tell the patient, well, you're going to have to pay $850 to get this test done.
Right.
The patient says, I don't have the money.
That happens very often.
Then what?
Then they go home suffering and their problem's not resolved.
And then it gets worse.
And sometimes you try to just diagnose on what you clinically feel is going on. You say, well, we're going to go ahead and treat it as such, but it sure would be nice to know with the tools that we have available So you know and I know that Dr. So-and-so is the one who said you shouldn't have this test. But really, they walk away without any liability in the care of that patient.
20 or 30%, according to experts, say that doctors like you have to go through worthless, meaningless tests in order to stop malpractice insurance. Do you see much of that?
Well, I think that we just do it naturally. I know that when you get involved, if there's ever a question of a patient having a problem, I said, did you order X, Y, and Z, X, Y, and Z? And that comes into play in a malpractice case. So we do see that, and I think we do overutilize some of our tests because of the malpractice risk.
How popular are insurance companies among patients today?
They're not very popular right now. You know, it's interesting. You watch commercials for other forms of insurance, and they talk about customer service. They talk about, we're there when you have your accident, and we'll take care of you.
We'll take care of you.
But we don't hear that with medical insurance, do we?
Why?
There's not enough competition. They don't have to do it. And their primary goal seems to be to make money, not take care of patients. So they don't even advocate that they're trying to take care of you at this point. They don't say you can count on us when you have need. I don't see it anymore. We used to.
Dr. Brad Wenstrup, when you say you can count on us and there's no competition, and therefore the insurance companies determine what level of care you get or what level of care they don't get, that normally begs the question. That means, well, then the federal government's got to get involved. Mommy and daddy's got to come in. If the insurance companies like United Healthcare are not acting correctly, or Anthem, what we got to do is get the feds involved. Is that a solution, or is that going even in a worse direction?
Well, I think it's probably going to go in a worse direction because I've never seen anything go to the federal government that made things better. You know, we have a system in this country. We have 50 states. We have 50 laboratories that can try different types of things, and we don't let them do it. Things should not start at the federal level. They should end up at the federal level if they need to be. But the problem is you do have too much involvement there, and I don't think that that's going to be the proper answer. It's just going to be more restrictions. You look at the chart that we have here, and you've got the IRS involved with health care now.
You know, the IRS is going to do investigations to make sure that doctors and laboratories and all the rest, and that individuals that don't buy mandatory insurance are going to have to deal with the IRS. They're going to come after you and seize your assets. It'll help if the IRS gets involved.
Oh, yeah, right.
That's going to help doctors and help the level of care when Obama mandating IRS investigations. That'll help.
There's nothing more comfortable when you're trying to do your job than feeling like there's someone back there, out there, that's looking to say, gotcha.
Yeah.
When really all you're trying to do is do your job. If there's bad doctors, that's going to be discovered. One, they'll quit getting patients. Two, insurance companies can pick up on patterns that don't make sense, that are wrong, and can intervene and take that doctor off their plan. But by and large, what's being done now is more in the name of money than it is in care.
Well, if Dr. Brad Wenstrup is the grand potentate, what would you do? Right now, it's probably less than 6 medical insurance companies in the tri-state handling over 90% of the business, and they're incentivized to make profits and make money and not to give patient care. What would you do?
Well, as we all know, the initial concept of medical insurance was to help you during a catastrophe, not to be an insurance company out there to make a lot of profits. So one of the sensible changes would be to get rid of some of the junk lawsuits. And you also need some punitive damages against some of the people that are inflicting some of these things. Insurance companies, for example, can make these decisions and delay payment and do all types of things, which increase the angst and anxiety of patients as they're already going through something that they're suffering from. And there's never any damage against them.
What about cancer? Because foot problems can be extremely painful and debilitating. But on the other hand, if you have a cancer and you can't get treatment from the insurance company because they don't want to provide it, and the doc thinks it ought to be provided. Say you got cancer of the liver, the pancreas, the stomach, the lungs, and you want to have these treatment, what A, B, C, and D. The doc says we got to do A, B, C, and D, and the insurance company says no, we don't approve that. Isn't that a large problem today?
That is a big problem, and it usually gets lawyers involved, and I can speak to that firsthand. When my younger sister, had leukemia years ago, and they were saying that bone marrow transplant is just exploratory. It's not proven yet. And that was her only chance of living. And I'm pleased to say 16 years later that she's alive, but we had to get a lawyer and fight the insurance company, and that only ended up in a compromise where they paid part of it.
And if you didn't get the lawyer and do it, she would have been dead by. She would have died.
Yeah, or we find ways to raise the money, but she's been paying into the insurance for a long time. And this was not something that was experimental. This is something that was proven. Granted, not everyone survives it, but it was her only chance at life.
Dr. Brad Wenstrup of Wellington, what happens after 10 to 20 to 30 years of Obamacare and the federal government is intimately involved in all this decision-making? Is American medical care in this country going to be better or worse?
I can't imagine it being better because there's no example in the world that said that type of care has made it better. And I also wonder who are going to be doctors, what type of people want to go into this
the best
profession.
and brightest aren't doctors. When you came up 15, 20 years ago, the best and the brightest became doctors. Now they go to Wall Street.
And one of my best friends, we went to UC together. He had a 3.9 in engineering, and senior year I said, why don't you think about medicine? He did. He's an anesthesiologist now. But he says today there is no way he would have entered this field. He would have gone on and been an engineer and still had some freedom to live his life, to have his own business, as opposed to what's taking place in medicine today. So there's not a real high incentive to run up a lot of bills for medical school and to endure all the training and then come out and have the IRS and other agencies all over you and not really let you practice your craft or getting involved with your craft in negative ways.
The best part of what you do is?
Taking care of patients.
And the worst part is?
Is the paperwork that goes with it.
What do you say if you're 30 years old and you've come out of 4 years of college, maybe 4 years of medical school and 3 or 4 years of specialization, you're 30, 31 years old, and you're ready to work the next 30 to 40 years. How much money do you think you generally owe coming out of medical school?
Oh, today it is around $260,000 in that range. Depends on the route you go. What
$250,000.
Yes.
You owe it.
Yes.
And you got to make that the next 10 years working how many hours a week?
Well, as many as you can get in. Patients have to come to you. When you start, it's difficult. There's very few people that just open up their practice on their own today because
you can't do that.
You can't do it. You can't negotiate. Insurance companies say take it or leave it on this deal. But if you're a larger group, then they need to have some providers.
So if you, in the good old days, you might be able to hang out your shingle. Much like practicing law today, nobody comes out of, in fact, less than 1/3 of the third-year students at UC College of Law have a job. 2/3 have no job.
Is that right?
Government's not hiring lawyers. You can't go out and put your shingle out and say, I'm 25 years old and I'll take all legal cases because that's the road to malpractice. You can't do that. You don't have the money to start. And large law firms, TS&H and Grant Henry Ritchie, those firms are laying people off. So you have no government. You can't practice privately. You don't know what the hell you're doing. And you can't go to large law firms or medium-sized law firms. They're laying off. So what do you do? Right. And you still owe $100,000 after law school. And you have no way to make money. Same thing in medical school, you're saying.
Yeah, you find a group that will hire you and let you come in under their wings. When I first started in practice, it was when managed care was just starting. My first year, I would see patients, I'd give them their bill, they'd submit it to their insurance company, they'd pay me. My collection ratio was very high. It became more difficult after that.
Because they would say, my insurance company didn't pay me, or they paid me 50 cents on the dollar.
Well, and what we're seeing now is the high deductibles and less privileges or less care being given. So patients that maybe had a $100 deductible or something like that before now have $500 or $5,000 deductible.
And many people like Medicaid. Medicaid is now costing about $300 billion a year. The government's paying for it. But would you take Medicare, Medicaid patients at Wellington?
Well, we take Medicare patients. We take few of the Medicaid plans because we found it cost us more just to take care of the paperwork than you could ever receive back. The other problem is right now we have very few Medicaid providers, and the new plan is going to increase the need because more people will be on Medicaid. So I don't know who these providers are going to be.
Who are they going to be? Because the so-called big firms like yours, Wellington and other really high-prestige places, don't take Medicaid because they can't make money. In fact, they guarantee to lose money, and you're busy enough already. Well, so where do these people? Where does the poor go?
Well, that becomes more and more difficult. So the problem isn't really solved, is it? Well, we do take some Medicaid, and we certainly do through the emergency room. You take self-pay or whatever. That's an obligation that we do fulfill.
But that's small, number-wise.
It can, yes,
because you can't survive. You got secretaries, and you got assistants, and you got computers, and everything's got to be electronic today. You have rent, you have insurance, you have all the other costs that's built into that bill, and you can't take Medicaid, otherwise you're out of business.
And as our reimbursement has gone down, all our bills are still there and going up. Nobody gives us a break. Duke Energy does not give us a break because we're in medical care.
The landlord doesn't say,
exactly.
Hey, look, you're a nice guy, Brad. You're doing a good work. We'll cut 10% off your rent. That don't happen. You can't go to Duke Energy and say, hey, you can't go to your secretaries and your assistants, administrative helpers, and say, hey, everyone's got to take a 10, 20% across the board cut because our reimbursement rates are so. You can't do that.
You can't do that. It doesn't work that way, and that's where we're stuck. So it's a very unique industry because we are so regulated. The government has been very interesting to observe over the years in my lifetime. I can't think of anything besides civil rights and women's suffrage that has given us more freedom or more liberty. Almost anything that's enacted today seems to take something away from what we used to have.
It used to be we get more freedom, more liberty. Now we have less freedom and less liberty.
Yeah,
and it keeps getting worse and worse and worse. And the solution to this by the government is to have larger government bureaucracies. We need 25,000 new IRS agents. Mm-hmm. We have to hire 25,000 more people with HHS. We have to have more charts. We have to have more reports. And doctors have incomes going down, expenses are going up. And at some point, the system breaks. Because now try to get a specialist. If you got a foot problem, try to get a specialist. If you have a shoulder problem, try to go see a specialist. They're not taking any, like Dr. Paul Lucky is my dermatologist. Yeah. Years ago, he told me, I'm taking no more patients. I don't want it, don't need it. And he's like the best in town. I'm lucky I'm at him. But he said, if you hadn't started here before 2006, I'm not taking any more patients. I can't handle it, and I don't want to deal with the paperwork.
Yeah, dermatologists, rheumatologists, those
can't get them.
Two right there. They're very difficult to get in to see.
So how does the government force that then? How does the government cram down into the system the need to see more patients when doctors aren't being compensated?
Well, they'll probably make incentives with money that they don't have.
Yeah. Well, Doc, we got to run. Brad Wenstrup, we'll do it again. And I'm going to try to put this chart on the station website, if possible.
Do you want me to send it to you electronically?
Send it to me. In fact, Lindsay, my producer, will give you an email. You send it to her, and then we'll put it on the website. We don't have to scan it that way.
Good deal.
And then we'll put it up there, and and this is from the United States government. Is it?
That's what it says right on it from the Joint Economic Committee, Congressman Kevin Brady and Senior House Republican Senator Sam Brownback.
All right, so this is real, and this is what we're facing today.
It's amazing they even could put it together.
All right, thanks, Dr. Brad Wenstrup. Bill Cunningham, 700 WLW.